Welcome back to The Nutshell, Alan. I think we should start by reflecting on when we last spoke to you. It feels like a really long time ago now.
I can't even remember. It was about 18 months ago.
It was, and I wasn't here, so I was really gutted to miss you. I'm actually so happy to be here talking to you today, Alan. So thanks for coming back.
Oh, thanks for having me. That's brilliant. And I'm really pleased that we're going to share this widely. So we'll be sharing this conversation on In a Nutshell podcast and on my new endeavor, the Eat This podcast with Dr. Alan Desmond. So yeah, it's great. And we've got some really nice topics lined up. So I'm looking forward to it.
Yeah, I mean, this is a big change. It's been a long time coming, but it was about time, I think, that we had a platform for you. How's it going with your podcast?
Oh, it's been great. Yeah. I mean, you know yourselves, it's so much fun, isn't it? Because you get to share all these long form conversations. I put a lot of content on social media, but you've got maybe 15 or 20 seconds to try and capture big concepts. So it's been really nice to share longer conversations and with some of the people who've really inspired me in my career professionally and even personally. So I had conversations with Dan Buettner, Tim Spector, George Monbiot. We've got Andy Ramage, the fantastic Rosie Martin, Dr. Gemma Newman. Most of the conversations I've been sharing actually are ones that we've recorded live at the live dinner and conversation events that I do in Exeter. It's been lovely to share those. It's been absolutely fantastic. And Steve and I are enjoying the process as well.
Oh, yes. Yeah. It's been good to meet Steve earlier on.
Oh, Steve's my producer. Sorry, I should mention. We were talking before. So Steve's the genius who produces the podcast for me. So we're both enjoying the process.
As we've said, most people, they know you from your social media platform. But of course, you are doing a full day job as well, aren't you? You're working in the NHS, you're seeing patients there. That is probably part of the reason why people see you as such a trustworthy source of information, I think, when it comes to any topics related to gut health and nutrition. And what we wanted to catch up on is the day in the life of Alan Desmond. What does it look like and how do you actually fit all this stuff in?
Yeah, it's busy for sure. And you're right. I work as a full-time NHS consultant gastroenterologist. And my passion for informing people about the benefits of a healthy whole food plant-based diet really stems from my experience speaking to patients about gut health and diet. And I've been doing that for a long time. I've been a consultant gastroenterologist for 12 years. I was probably training to be a gastroenterologist for more than 12 years before that. So it's those conversations that I have with people every day in my NHS clinic and also in my private clinic that really inform my passion for talking to people about this. And just often, of course, in the hospital, I mean, when we talk about conditions like diverticular disease and bowel cancer and Crohn's disease and fatty liver disease, and all of these conditions, which are strongly linked to the standard Western diet, which can be prevented, reduced, ameliorated by a healthier plant-forward approach to food. Often it's very interesting, but it can sound a little bit academic. I guess in the hospital every day, I see people who are at the sharp end of that, or at the very bottom of that slippery slope, where they're living with the very severe life-limiting and life-threatening complications of many of these conditions. And for example, this week I've sat down with two patients this week to inform them that I just diagnosed them with bowel cancer. They've had a colonoscopy. So I've just diagnosed them with bowel cancer. And every time, that's never an easy conversation. And after every conversation I have with a patient explaining that new diagnosis to them, I know their life is going to be changed utterly by what just happened. Even with a good prognosis, they're going to be looking at surgery, chemotherapy, and years of worry. With a poor prognosis, they now have a limited life expectancy. The 5-year survival on average being about 65% with colon cancer. So every time I walk away from one of those conversations, I reflect on the fact that more than maybe 1.5 million people have that same conversation with a doctor every single year. And we very much know that a healthier diet and lifestyle could reduce the burden of that disease by up to 80%. So we would have 80% fewer people needing that conversation. So it's those conversations and those experiences that make me so passionate to do things like we're doing right now and spread the word. But on a day-to-day basis, I mean, my wife Hannah and I have 3 children, so it's we wake up at a time that's predetermined by our 8-year-old son, which is usually early. Then there might be a little bit of Lego, a little bit of reading, breakfast, coffee. Make sure the kids are set and ready to get out the door. The older ones kind of are pretty independent now. They'll get themselves set and out the door. But yeah, coffee and brekkie are definitely part of it. Then a drive into work. And then once I get to the hospital or my clinic, it's me in the endoscopy unit doing procedures, sadly, often diagnosing people with GI cancers, performing endoscopies, having conversations about gut health and medications and treatments. And it's about everything that you would expect an NHS gastroenterologist to be doing. And so my days are a mix of seeing patients, performing procedures, being on the ward, talking to families, being part of the multidisciplinary meeting with dietitians and nursing colleagues and all the other incredible people who work in the NHS to provide the services that we provide. And my day usually at the hospital will end around maybe 5:30 or 6 p.m. And then it's gym and home. And I find getting to the gym straight after work really, really helpful. We all know about the benefits of exercise and movement, and that's important. But also, it's a nice little reset to kind of get out of the clinical headspace, take maybe 45 minutes where you're focusing on nothing other than, can I do another 10 burpees or whatever? And then you get home and ready for all the challenges that are often waiting at home when you got a busy household with 3 kids, so home in time for dinner and chats and, just family life then in the evening, And somehow then we managed to fit in a little bit of content creation and social media posts, which I view as really important because, like yourselves, I think we need to have evidence-based voices in the public space. God knows there is so much misinformation online. And I think we all have a responsibility to be out there trying to combat that.
You mentioned those cases of bowel cancer being diagnosed and what you have to say to somebody in that situation. But obviously, so much of what we do is about trying to prevent things happening in the first place. And yet, when we look at all the trends, things are getting worse. People are getting, rates of obesity going up, rates of bowel cancer seem to be going up. How do you stay so positive? Because you do seem really positive about this. How do you stay so positive when we seem to be slipping on the prevention side of things as a population?
Gosh, there's a lot that keeps me hopeful. There's this old saying that hope isn't an emotion; it's an action. So you feel hope, but you act with hope as well. I think what keeps me hopeful is that I see all the time the small changes really do make a difference. I see that both when I look at the medical literature. And when we look at all the studies about getting people to even slightly change their diet and lifestyle in a positive direction, it can have really, really meaningful impacts on their personal health, happiness, and longevity. I mean, and then I see it in my clinic as well, even when people make small steps towards eating more healthier, whole food, plant-based meals. And, a patient comes back to me and says, yes, I've cut down on junk food. Yes, I've cut out red meat. Yes, I've cut out processed meat. Now I'm eating more beans and greens. My dietary fiber has gone from 12 to 30, and I'm now feeling more energetic, or my digestion has completely changed, or I've reduced my meds. I'm feeling happier, more. When you see that played out at clinic all the time, that really gives me hope. And I think the fact that more people in the public space are really engaging in conversations about gut health and the gut microbiome and the importance of all that, that also gets me really fired up. I mean, there was a paper just published yesterday. No, not published yesterday, but published just last month. But I was just reading it yesterday, and it was a study out of UCC, my alma mater, the APC Microbiome Research Center, where I worked. Gosh, maybe 14 years ago, for 2 years. They've just shown, they put people on what they call the restored diet, so a very healthy plant-forward diet. And they showed that in just 3 weeks, they could get these volunteers to reduce their cholesterol, lose body fat, improve their blood pressure, reduce their CRP in just 3 weeks, and that their gut microbiome got measurably healthier in just 3 weeks, but also that their gut microbial diversity went down a little bit. And that's interesting because we always talk about promoting gut diversity. But of course, the truth is that it's not just about gut diversity. It's about having enough of the healthy bacteria that are producing the short chain fatty acids and everything. And I was just saying to my wife this morning as I was leaving to come do this podcast, I said, I read this paper yesterday. This is really interesting. This has got me really fired up. I want to let more people know about that. And it all just feeds back into the same thing. I mean, genuinely, on a day-to-day basis, seeing how these small changes can make people healthier. So that makes me really, really hopeful. And engaging and letting people know about the power of this is really, really important.
Well, you mentioned there people in the policy space taking more an interest in things like the microbiome. I don't know if you've got the ear of the health secretary in the UK. He may be following you on Instagram, Wes Streeting. But let's take a step back from that and say, if you were the health secretary, what is the one thing that you would change?
So I'd probably completely rework the way we approach public conversations about nutrition. So right now in the UK, we are seeing every day of the week the consequences of a fibre deficient diet. Diverticular disease, bowel cancer, heart disease, even mental health disorders and depression. These are all very strongly linked to gut health, poor quality diet, and fiber deficiency. So maybe if I was health secretary, which I don't see happening, I'd be the fiber first health secretary. So I'd be making policies about dietary fiber, making high fiber foods the default in hospitals, schools, and public spaces. Right now, the average UK adult gets less than 20 grams of fiber per day, but research suggests we should all be aiming for 40 to 50 grams of fiber per day. So if we normalized, incentivized, subsidized fiber rich foods and made them more accessible and educated people on these simple ways to incorporate them into their day, we'd be tackling multiple chronic diseases at their root cause. We'd be saving the NHS billions of pounds every single year. I think if I was to be a little bit more realistic, if I was the UK Health Secretary tomorrow, but I still think it would be very ambitious, is I would dust off the food strategy document that was produced about 4 years ago. And so that called for doubling of dietary fiber intake, a substantial reduction in red meat intake, etc. And I would implement that policy to its fullest force. And then I would think, okay, now we've implemented the food strategy, which the government at the time completely abandoned. And I'd say, now that we've fully implemented the food strategy, we're ready to make some really healthy changes. And then we'd move into phase 2, which would be fiber first healthcare for the UK.
And of course, if we had fibre first healthcare, it wouldn't disappear overnight because the damage has already been done, I think. But that kind of takes us on to what we wanted to talk about today, doesn't it? Which is, you mentioned diverticular disease. Lots of people won't even have heard of this, but they might be suffering from it.
Yep. Absolutely. So that's a very specific condition. Yeah, I think it's a good one to speak about today, actually. I think in medicine in general and gastroenterology in particular, diverticular disease is a slightly neglected condition. It's like not a very, it's not very topical. It's not very cutting edge. When we go to the medical conferences, we certainly don't have rooms packed full of doctors very keen to learn more about diverticular disease, which is a shame because it's a condition that's really, really common in the UK. So if you're, in the UK, your risk of having this condition is approximately in percentage about your age minus 10. So if you're 60, there's about a 50% chance that you have diverticular disease. Okay, if you're 80, there's about a 70% chance that you have diverticular disease. So this affects a lot of people. So diverticular disease occurs when these small pouches or diverticula form in the wall of the large bowel or colon. Now, a lot of people may not even realize they have them, and they may be found incidentally when people have a scan or a colonoscopy. They don't know they have them until they become a problem. Because if these little pouches become inflamed or infected, it causes an inflammatory infective condition called diverticulitis, which makes people feel terrible with severe pain, bloating, diarrhea, raised inflammatory markers. They may need to have a course of antibiotics, and sometimes they can end up with very serious complications such as perforation. I've taken care of patients who've needed emergency surgery for diverticular disease, even some people who've died from diverticular disease. So that's what diverticular disease is. And we certainly know that diet has a lot to do with diverticular disease. So, in fact, diverticular disease was one of Dr. Dennis Burkitt's original diseases of Western populations of fiber deficiency. So we know in Westernized countries where we eat the standard global diet, standard American diet, standard British diet, diverticular disease is really, really prevalent. And the dietary risks are specifically fiber deficiency and red meat consumption. So, in populations that consume more than 40 grams of fiber per day, you will see virtually no diverticular disease. In contrast, in the UK and the US, where fiber intake is much lower, up to 50, like I said earlier, about 50% of adults over 60 have diverticular disease. And that's a big difference. And it's not just about fiber deficiency. There's also a clear link between flare-ups of diverticular disease and red and processed meat consumption. So we've seen several studies showing that people who, in a population who are higher consumers of red and processed meat, are much more likely to have diverticular disease, but also much more likely to be hospitalized with complications. Because red meat, if you've got an already fiber deficient, damaged gut, Red meat helps to promote inflammation and oxidative stress and alters the gut microbiome in ways that could contribute not only to the formation of the diverticular disease, but recurrent flare-ups that might need antibiotics or hospitalization. So reducing or avoiding red meat while increasing the intake of healthy plant-based sources of fiber is excellent advice for someone with diverticular disease. And like I said, it's important because, in the UK, we see this played out in our hospitals all the time. We've got nearly 50,000 hospital admissions every year with complications of diverticular disease. And there's a 1 in 20 chance that people who are admitted with complications of diverticular disease will actually die in hospital. So it's a very, very common disease. It's true that it's relatively unlikely to bring about the end of your life. It's unusual that you get very serious complications, but they do happen. And a lot of people are living with a lot of symptoms, and they get very poor dietary advice. Often they're told to eat a low fiber diet, not eat nuts and seeds. And it's this old school non-evidence based medicine. Oh, you've got a condition that sometimes can cause cramps and diarrhea. Therefore, we should put you on a constipating diet, and that will help you. But of course, the opposite is true. At clinic all the time, I'll speak to my patients with diverticular disease about cutting out red and processed meat, gradually increasing the dietary fiber. And this helps to keep them out of hospital. I had a lovely elderly lady come to see me at clinic about 18 months ago, Rose. Rose had been hospitalized 3 times in 1 year with bouts of acute diverticulitis. She's in her 70s. She lives alone. She finds being admitted to hospital absolutely terrifying. She's a very nice lady, but she just does not want to be in hospital. And on her most recent admission, she was told by one of the doctors that if she had another flare, she might need emergency surgery and that she could potentially need a bowel resection and end up with a stoma. So she came to see me at my clinic just saying, look, is there anything else we can do about this diverticular disease? Now, no one had spoken to Rose about dietary change other than telling her to eat a constipating low fiber diet. So I worked through that with her. She was of Indian heritage, actually, and really enjoyed rediscovering the variety of plants and traditional foods that she'd enjoyed during her childhood. So she was bringing in more dals and, delicious leafy greens and all this sort of thing. So gradual change was key for Rose because she'd been advised to eat a low fiber diet for many, many years. And I recently saw her at clinic, and I think it's been about 12 months since she first met me. She's loving her food, and she's not been admitted to hospital since. She just has these sensible strategies. And of course, I wouldn't change my entire practice just based on Rose's story, but we're following evidence-based advice here. We're getting evidence-based results. And when you see someone coming back to see you at clinic, and their goal was to stay out of hospital, and they've not been admitted to hospital for 18 months, and they're enjoying their food and their blood biomarkers are good and they're not having flare-ups anymore. That just shows a huge difference on how diverticular disease can be modified by simple dietary changes. And of course, when you look at just preventing diverticular disease, I mean, we've known since the 70s that vegans in the UK are substantially less likely to get diverticular disease. After Dr. Dennis Burkitt started talking about this in the 70s, there was a great study done in the UK. I think they did barium enemas on asymptomatic adults, and they found that even then in the UK, vegans were very much less likely to have diverticular disease. And they reckoned the reason why was because they were getting twice as much fiber as omnivores. So that was, I think, a 1974 study. And the omnivores were getting 20 grams of fiber per day. The vegans were getting 40 grams of fiber per day. And they were far less likely to have diverticular disease.
Can we just come back to what you said there about poor old Rose, who's now doing well? I hear that. But she was told to follow a low fiber diet. And, this is what we often hear from our patients as GPs, that people come in and they say, I think I've got a flare of something, but I'm told to avoid all these foods. Are you taking on colleagues here in terms of the guidelines?
If we speak specifically about diverticular disease, okay, so the evidence is very, very clear that vegans and vegetarians and people who get sufficient dietary fiber are far less likely to even get diverticular disease. Also, that if you have diverticular disease, a healthy dietary pattern which is a healthy Mediterranean or plant-based diet, means that you are less likely to be hospitalized with complications. So the best approach, no doubt, is a plant-focused, fiber-rich diet that supports gut motility, nourishes beneficial gut bacteria, creates a gut microbiome that is not conducive to chronic inflammation, that is not conducive to infection. Okay, so you want a healthier gut microbiome, and you can do that by minimizing inflammatory foods like red and processed meats, and by focusing on fruits and vegetables, whole grains, legumes, nuts, and seeds. Okay. But I think if you have a patient who is hospitalized, so they've come into hospital, they've got an abscess or a perforation, they need a lot of antibiotics, they may even need surgery. It's true. So, in order to reduce their pain and diarrhea, at that time when their gut is very badly inflamed and diseased, we will often recommend reducing dietary fiber in order to reduce symptoms of pain and distension and diarrhea. But I have to tell you, although we do that, and that is standard practice, there's two important things to note here. That has never been studied. So we don't have any studies showing that that's the correct thing to do. So that we haven't had any studies where we have randomized patients with acute diverticulitis in hospital. Now, ideally you would do a study where everybody gets the standard of care, antibiotics, fluids, CT scan, etc., operation if needed. Okay, but that you would randomize them to either one group is given a healthy high fiber diet and the other group is given a fiber deficient white diet. And then you would look at symptoms, time in hospital, length of antibiotics, inflammatory markers, etc. And then at the end of that study, you would say, yes, in the short term, we should put them on A or B. It's never been studied. So the advice to put people on a low fiber bland diet, it's remains standard advice, and I understand it from a very basic, what we know about how the colon works, it kind of makes sense. But as Dr. Greger says, you got to put it to the test. We've never put it to the test. The second point on that is that should not be a permanent intervention. So we know that there's a few reasons for that. Number one, I've already explained that a healthy diet helps to reduce further flare-ups, etc. That's important. But also, guys, I mean, the side effects of putting someone on a long-term low-fiber diet in terms of their overall health, their increased risk of type 2 diabetes, various cancers, hypertension, obesity, you name it. I mean, if a low-fiber diet was a pill, I don't think it would be approved for use, because the long-term side effects, not to mention the boring food, but in terms of the health effects, the overall health effects of a very low fiber diet, just have serious reservations. And I also get concerned when I see people who've developed a disease that is a consequence, although there is other factors, of course, genetics play a role, there are other factors involved in diverticular disease, but the standard fiber deficient, high meat, high dairy, high junk food, high processed food, low fiber diet that has become the global standard diet, standard British diet, strongly implicated in diverticular disease. So I then get a bit concerned when someone develops diverticular disease and the only advice they're given is to eat even less healthily. Oh my God, you're eating an apple a day. Stop eating that one apple. It's going to ruin your gut. Of course, it's not true at all. And that kind of feeds into can we debunk nuts and seeds and diverticular disease?
I hope so. As I say, there's something funny that happens when people have been into hospital with something acute. And I don't know whether it's because the time that people have to talk to them about stuff is quite limited, but they definitely come out of hospital having inherited this idea that they need to avoid a whole load of seeds and nuts and tomato skins. And, you can have an apple, but you've got to peel it. And just sort of crazy stuff that they carry on for years until you see them at their next flare or their next episode of constipation, and they've internalized all of that, or they've been given some leaflet that seems to be advocating for that.
What you're alluding there is actually a really important point, that the dietary advice that people are given in hospital needs to be very well thought out and very evidence-based, because the dietary advice that people are given in hospital, they will often carry that forward for many, many years, and very reasonably, they will take that advice seriously because it's been given to them by a health professional in hospital when they are at a very vulnerable point in their life when they're unwell and hospitalized. That's an important fact. That's why when we have conversations with our patients about food, we need to make absolutely sure that we are giving them evidence-based practical advice. And you're right. I see patients all the time with Crohn's disease, ulcerative colitis, diverticular disease, whatever. And at some point, they were told to eat a low fiber diet. And I've seen patients then who come to see me, who will come to clinic with constipation and bloating and distension. And when you start talking to them about food, it turns out they're living on white bread, Rice Krispies, and chicken breast, and that they've spent the last 25 or 30 years avoiding fruits and vegetables and whole grains and sweet corn and all of these foods and nuts and seeds because at some point they were hospitalized and someone told them to avoid those foods. We need to be really mindful of the impacts of the advice that we give to our patients. So the nuts and seeds thing and diverticular disease is by far one of the biggest myths in gastroenterology. The idea is that small particles from nuts and seeds, when you eat them, would get stuck in the little diverticular pouches, block them, and trigger inflammation. Studies have completely debunked that. In fact, we know for sure that people who eat more nuts and seeds as part of their daily dietary intakes tend to have better gut health overall. They're rich in fiber, they're rich in healthy fats and polyphenols that promote a healthy gut microbiome. So rather than avoiding them, I encourage everyone, whether or not they've got diverticular disease, to consider having some nuts and seeds as part of their healthy diet. One of the reasons that gastroenterology is the best medical specialty. No, I'm just kidding. The reason it's one of the better medical specialists, if not the best medical specialties, is because we get to examine through endoscopy the living organ that we're treating. So I've done thousands and thousands of colonoscopies. I have seen probably millions of diverticula in the colons of people with diverticular disease. And I have never seen a nut or a seed jammed in one. What you see jammed into diverticulae are hard, constipated little lumps of constipated, fiber-deficient poops that even the bowel prep that we gave the person to go in for the colonoscopy hasn't managed to budge. So if you do have diverticular disease, and I think it'd be useful just to talk about the symptoms of diverticular disease as well before we finish, and why it's important to see your doctor if you're concerned that you may have diverticular disease. But if you do have diverticular disease and you've been studiously avoiding nuts and seeds for a few years, maybe go and buy yourself some crunchy peanut butter and bring it in gradually and see how you tolerate it. The odds are you will tolerate it just fine. In fact, it'll probably be to your benefit.
Yeah, you mentioned that, the bowel prep, and that's so often what we see, and we don't really know what it looks like as a GP, where it just says, we've done the colonoscopy, poor bowel prep. And, and you haven't quite seen all of the bowel or what you wanted to see, but it's good. I'm so pleased to know that it wasn't a bit of walnut obscuring your view.
Nothing wrong with walnuts, Claire. You know they're my favourite nut.
They are.
They're the best nut. The best nut.
They are.
What I was wondering, because we've often thought about this as a little project, plant-based health professionals, is do you think we're still able to find leaflets, NHS leaflets, that tell people to avoid things like nuts and seeds if they've got diverticular disease, or has that been updated now?
Oh no, I'm sure they're probably still in NHS hospitals all over the UK. Yeah, but like I said, in the short term, for people with severe flares, maybe there's a role. It's certainly standard advice now, but it's never been studied. We don't have any data to support that statement. Just a lot of anecdotes. It's just standard practice is one of these accepted norms, and it's fine. That's okay. But as long as that advice is not permanent advice, that's the important thing.
And I think that's really important for us as GPs, because we're then following people up, like you say, Alan, more long term. They've come out of that acute flare, and then the advice that we give them really kicks in. And I think a lot of GPs, well, certainly I was confused. So it's really, really useful to have you clarify not to be scared of fibre with these patients, and perhaps introduce it slowly after their flare up. But going back to symptoms, you mentioned just clarifying how someone would know. Generally, I think we as GPs tend to find incidental finding, on a report if someone's had a test for something else. And quite often, I think the first time I see a patient with symptoms is when they're having that acute flare, that diverticulitis flare up. But can they get symptoms before the flare then?
Yeah, so typically the symptoms of diverticular disease can range from mild to severe. So commonly people who have diverticular disease, they will have episodes of abdominal discomfort, usually on the lower left part of your tummy. The sigmoid colon, which is this S-shaped mobile part of the colon on the left-hand side, is most likely to develop diverticular disease. That's where the stools passing through are formed. They're nearly ready for the outside world. So they're solid. There's more pressure in the lumen at that part of the bowel. And the pressure within the lumen of the bowel, or the channel of the bowel, really contributes to the formation of diverticular disease. So those little pouches can sometimes get slightly inflamed, and that can cause a little bit of discomfort, maybe a little bit of bloating, a little bit of nausea. If they get infected, where basically you've got an overgrowth of bacteria within that little pouch, because of course it's the perfect little petri dish to grow tons of bacteria, right? It's like within the bowel, one of those microbial rich environments on earth. If that becomes infected with an imbalance of harmful bacteria, you can get fever and just feel generally unwell. And sometimes, as you know, people who are experiencing these symptoms will come into clinic feeling unwell and feeling feverish. And when you examine them, you examine their tummy and you press on that part of their bowel, and it's really sore and tender. So if someone is experiencing symptoms that makes them suspect they may have diverticular disease, it's a really good idea to have a chat with your doctor, go in and have a physical exam. The symptoms of diverticular disease usually would warrant some form of investigation, and have a chat with your doctor. Do you need to have any poop tests, like a fit test to look for abnormal blood loss? Do you need to be referred for a colonoscopy or a CT scan, just to see if these symptoms represent diverticular disease, or is there anything else going on in your tummy that needs to be checked out?
Absolutely. And if someone has already got a diagnosis, I mean, I've got a patient I can recall who has, multiple episodes of these flare-ups, these infected flare-ups, diverticulitis.
Mm.
What makes some people more likely to have flare-ups and others not so?
First of all, there's the dietary risks. So, if you are eating a diet that promotes inflammation, as we discussed earlier, so a fiber deficient, high meat, high red meat, high processed meat diet, cigarettes and alcohol don't get off the hook either. So, both of those can increase your risk of flare ups. So, it's certainly worth having a serious chat about someone about their diet and lifestyle in that setting. But there is also a genetic component to diverticular disease, and it is true. We will sometimes see people who present it at a young age, and they've got very severe diverticular disease affecting all of their large bowel. And that would, for those individuals who are rare, that would seem to be a genetic issue where the wall of their colon is somehow deficient. So these diverticulars start forming very early in their life. Just to be clear, this is an unusual scenario, but those individuals can have ongoing symptoms of abdominal pain and excess fermentation and gas and bloating. But you're kind of getting into specialist areas, and hopefully that person will be at a gastroenterology clinic having pretty individualized treatment. But you're right, some people can be prone to more flares. And then if the disease is detected at a very advanced stage, the damage to the bowel can get pretty gnarly because repeated episodes of infection generate adhesions and discomfort. And those individuals can have ongoing symptoms even when nothing is inflamed. And that can be really challenging for people. And that's why it's really, really important to talk to people publicly about the benefits of a healthy high fiber diet, because we could prevent this condition decades before it ever bothers you, like so many chronic conditions.
Absolutely, yeah. And in flare-ups, again, going back to the same patient, she's almost asking me for antibiotics to keep in reserve because she knows that she needs them at that time. And I really worry about how many antibiotics some people do need. And obviously, if they need it, then that's understandable. But you sort of worry, don't you, when you're prescribing an antibiotic and the effects that can have on the gut microbiome? Do we know any links between the changes in the gut microbiome and flare-ups?
Well, any antibiotic that's going to treat a GI infection is going to potentially alter the gut microbiome. But of course, it's a risk balance thing, isn't it? You don't want to leave someone with diverticulitis, which can be potentially life-threatening, untreated. And the treatment is antibiotics. So we shouldn't be scared to prescribe antibiotics to people when they need them. The key is when they need them. We don't have great studies actually looking at the impact of what happens to the gut microbiome whilst things are flaring up. So maybe that's another study we need to do. Like I said earlier, diverticular disease is a slightly neglected topic in gastroenterology.
So many good ideas today,
There's so many good ideas today. So if anyone has a bunch of research funding and that they'd like to send our way, that would be awesome. We could really open the book on diverticular disease.
Definitely. And for the doctors or the GPs listening, we talked a little about prescribing antibiotics when there is a need. Obviously, again, we worry about pain relief. Certain painkillers can be very constipating, making matters worse. Some can be very irritable on the gut lining and causing inflammation. Where do we go with treating pain for somebody with diverticulitis?
Yeah, hopefully you can just use something simple and relatively non-toxic like paracetamol, maybe paracetamol with a little bit of codeine in the acute phase. But again, the codeine can be constipating, which can cause more problems. I think if someone is coming in with a flare of diverticulitis to the point where you're thinking they might need codeine, then really you need to be looking for infection and wondering if you need to treat them with a course of antibiotics. So the pain shouldn't be an ongoing issue. That we should be able to get on top of that. I found it very interesting earlier when you mentioned that you will often see diverticular disease as an incidental finding. And I guess that just speaks to how prevalent it is in the UK, that you will get CT scan reports back and the diverticular disease will just be included as a normal finding rather than a problem, as if it's just a normal part of aging. It's one of these things, isn't it, where we view so many chronic health conditions in the UK as a normal part of aging. I mean, that normal scan will probably also say to you, yeah, it's a normal scan. They have sigmoid diverticular disease and fatty liver disease. These are normal.
Yeah.
It's that can also often be a little bit depressing, even within, and it's a thing that happens in medicine, isn't it? We've referred to this as diverticular disease for decades, but many doctors will now refer to it as diverticulosis. So it's a softer word. It's less stigmatizing. It doesn't sound like it's a disease process. It normalizes it. And you can argue the pros and cons of that, but it makes me a little bit sad when we take disease processes and then we normalize them.
I think it makes us sad because we know it doesn't have to be that way.
And also, it should prompt a conversation with the patient.
Yeah.
So a finding of diverticular disease should prompt a conversation with the patient. A finding of non-alcoholic fatty liver disease or steatohepatitis should prompt a big conversation with the patient. But if you just include these as normal things, then we're normalizing poor health. We're normalizing conditions that, while they may not be affecting someone in a very measurable way right now, they're highly likely to affect them later in their life and reduce their quality of life, maybe their quantity of life. So these normal findings should prompt conversations with our patients for sure.
And we had a couple of additional questions, but they're a little bit more niche about, are there any associations with things like hypermobility, and should certain people be concerned about their risks of diverticular disease if someone is concerned?
If you have a hypermobility syndrome, that tends to be something of a collagen disorder, doesn't it? So your tendons and collagen doesn't form so well in your body, which is usually a genetic issue, right? I'm not an expert in hypermotility syndrome, but sure, there is a potential link there with diverticular disease because we've got the same concerns about the integrity and strength of the gut lining. But I think that's very niche. That's a very niche question.
Yeah, sorry, I don't know where I read that. But no, that's been really helpful because I think in my mind, it's really clarified diverticular disease, what to look out for, how to speak to patients about their diets, not to be afraid of fibre, particularly if they're not in an acute flare. Actually, fibre-rich diets are so helpful in so many aspects.
Where we're sort of identifying that we're normalizing diverticular disease, it's the same with hemorrhoids, isn't it? That's another thing that just gets mentioned. And to me, it's a bit of a red flag that someone's got a bad diet when they come in with hemorrhoids. There can, of course, be genetic reasons for that too. Yeah, it's just a really interesting observation how we sort of almost reassure patients and say, there was nothing on your colonoscopy, just some hemorrhoids and diverticulosis. And can I say, for the interest factor, so I'm hypermobile and my colonoscopy was A1.
Oh, was it?
Excellent.
It might have been your question then.
It wasn't. I'm
I
hypermobile.
hope your prep was A1 as well. I hope you followed the instructions. And of course, we need to mention that on the homepage of Plant-Based Health Professionals UK, we've got a great patient information leaflet on getting ready for your colonoscopy.
Absolutely, yeah.
So getting ready for your colonoscopy is a very artificial process. So the large bowel is a miraculous organ, home of the gut microbiome. It didn't evolve to have colonoscopies, yet colonoscopies are really, really important. And I'm a huge fan of having recommendations that people should have a colonoscopy. If they're worried, they should take part in the National Bowel Cancer Screening Program. Really, really important. And colonoscopy can be a little uncomfortable, but it's in the 21st century, in 2025, it is a very safe and well-rehearsed process. So don't be scared to go for a colonoscopy. But when you're getting ready for colonoscopy, it's a very artificial process. So most units will recommend that you eat a very unhealthy, low-fiber, white, microbiome starvation diet for 1 or 2 days, maybe 3 days before your colonoscopy. The reason for that is because we want to dramatically reduce the amount of poo that you're making for a few days. Okay, so we put you on a really unhealthy diet for a few days of white rice, Rice Krispies, that kind of thing. After that, we then give you an artificial medicine that really cleanses out your bowel and puts you into the bathroom quite a lot. So we reduce the amount of content in the bowel artificially, and then we clean it all out artificially. It's a very artificial process. But many units, when they provide the dietary information sheets for those few days when you want to be eating really unhealthy, it just has things like chicken and cheese on it. Okay. So we know those foods. If you're just eating chicken, cheese, and bacon, you're going to really starve your gut microbiome, and it's designed to do that. But luckily, at Plant-Based Health Professionals UK, we have a vegan-friendly version. If we've got any vegans listening today who are getting ready for colonoscopy, check that out. Maybe we could put it in the show notes today. It's
Brilliant idea.
really helpful information leaflet. And I'm going to anticipate your next question. What does colonoscopy prep do to the gut microbiome? Were you just about to ask me that question?
It's always about the gut microbiome.
Before you go on to that, I've sort of got a supplementary,
Okay.
which I hope I'm not going to put anyone on the spot here. Daisy and I, we talk the talk when we do the podcast, but we're obviously not scientists. And when we talk about delving into research, we haven't actually, we'll say we've done some research, but obviously we're not researchers. We just read papers and things. And I was reading something the other day because I thought about how we always say this sentence, don't we, Daisy, where we talk about how fibre allows your bacteria in the microbiome to make short-chain fatty acids, and these get absorbed back into the bloodstream. And I thought about, well, do any calories come from that? And then I read something and it said, yeah, about 10% of a person's calories will come from the absorption of short-chain fatty acids. And then I thought, so if somebody wants to lose weight, and they've got like a terrible microbiome that's not making lots of short chain fatty acids, does that actually decrease the number of calories that they're getting from their food? Because we're talking about when you go on a low fiber diet, do you actually get less value from the food?
That's a good question. The short chain fatty acid thing is super interesting. So in humans, we can divide. We saw the gut microbiome global atlas published late last year out of London. So a global atlas of the gut microbiome. Okay, so I can't remember. I think maybe I can't quite remember the number, but several thousand volunteers in, I think, about 21 different countries around the world, giving gut microbiome samples, giving poop samples for science. We could talk about that, the findings of that paper for hours. But the big take home was that we can now divide people on Earth into two groups depending on the gut microbiome: the industrialized microbiome and the non-industrialized microbiome. So the non-industrialized microbiome is dying out, and that would be the Prevotella predominant enterotype. So this is a gut microbiome in humans, which is the preferable beneficial gut microbiome that takes fiber, ferments it, and produces short-chain fatty acids. So in humans, we have those two broad enterotypes, maybe three enterotypes. So Prevotella is the goodie, the best one we can get, okay? If we look at some of our very near genetic relatives, lowland mountain gorillas, living in rural Africa, So they are like 98% genetically human. You see those pictures of these gorillas, and you can see it's like looking at an almost human face. Okay, it's startling, isn't it? They have 98% of the same genetic material as us, but they're apes. They're not humans. They're lowland mountain gorillas, but they live in nature. They live out in the wild. They forage for their food every day. They eat a high fiber plant-based diet, and they vary their diet seasonally according to what's available. And looking at their gut microbiome, and researchers have done this, and I love the idea of researchers following Western lowland mountain gorillas around to collect their poo and then bringing it back to the lab to study it, but it's been done. And so when we look at their gut microbiome, they've got like 5 different enterotypes. So not only do they have a more diverse gut microbiome than humans, they have like enterotypes that humans don't even have. And in fact, the Prevotella enterotype in these guys and girls, these apes, isn't even the most efficient at metabolizing fiber. It's one of the less efficient enterotypes. So that kind of gives us a real insight into what the ancient human gut microbiome may have looked like. But the reason I bring this all up is because during the dry period, when they don't have access to a lot of fruits and and they're basically living on seeds and barks and roots and things like that, during that period of time, they're on a super high fiber diet, but their gut microbiome, their colon, is metabolizing so much fiber and generating so much short chain fatty acid that those short chain fatty acids actually become a really important part of their caloric supply during those difficult periods when food is scarce, and can actually provide up to 70% of their calories. So their gut microbiome is feeding them calories from their bowel. I mean, I'm not suggesting a human goes out and lives on bark and seeds. We just don't have that capability anymore. But it's super interesting. But of course, in humans, when we eat a high fiber diet and we push ourselves towards that Prevotella predominant gut microbiome, that plant powered gut microbiome, that's the optimal way to produce short chain fatty acids by saccharolytic fermentation, break down starches. We can also produce short chain fatty acids by breaking down protein, including animal protein, by proteolytic fermentation, but it's a far less efficient way to produce short chain fatty acids. And not only that, the byproducts of it are generally harmful, so secondary bile acids, etc. So the proteolytic byproducts are generally unhealthy, but you will get some short chain fatty acids if you're fermenting fiber. By saccharolytic fermentation, you're optimized for the production of short chain fatty acids, and the other postbiotics that you produce are beneficial to your health. So it's all good news. About maybe 70% of those short chain fatty acids enter your bloodstream, so they do really benefit your overall health. They've got so many benefits. But in terms of weight loss specifically, they do help to control your appetite. They do help to regulate blood sugars, and in fact, they activate many of the same pathways that are targeted by drugs like Wegovy and Ozempic, which are essentially tricking your body into thinking that you're producing tons of short chain fatty acids and that your body is producing tons of GLP-1.
That is fascinating. Claire, I mean, what an answer. Were you expecting to get, has that answered your question?
It has. And I guess looping back, what we were originally talking about was what was the impact of the bowel prep?
Oh, sure.
On the gut microbiome.
So that's a question that people ask me all the time.
Will you lose weight?
Well, one thing. Well, you lose some volume, that's for sure, with the bowel prep. But it's interesting because the gut microbiome is a lot tougher than people think, and there have been several studies looking at this. In fact, one of my colleagues at the hospital that I work at, Dr. Sam Poles, was a co-author in a paper looking at this specific topic. Good news, folks. Having colonoscopy, doing bowel prep has almost no impact on the health of your gut microbiome, because even though we give you all this bowel prep, there is enough residual fluid even on the best prepped bowel. And also we have the mucosal microbiome. So this is the microbiome that lives in the mucin layer that's interacting very closely with the lining of the gut. So that's not affected. There's enough residual microbiome there to seed your microbiome back. And in fact, the studies show that, surprisingly, that having a colonoscopy has almost no impact, positive or negative, on your gut microbiome. It bounces back within days.
Good to know. Well, Alan, it's just been fascinating. We've got so many questions to ask you. For the purposes of time, we were wondering whether you'd be happy to stay on, and perhaps we can do part 2 of our our interview with Dr. Alan Desmond. Would that work for you?
Yeah, that's great. I think we've got another important topic to discuss.
We certainly do. So listeners, we'll bring you more from Alan in part 2, where we ask the expert everything we need to know about how to reduce the risk of one of our most common cancers in the Western world, and that's bowel cancer. So make sure you tune in for that. But for now, for today, thank you, Alan. Thank you very much.
Thank you. It's been a pleasure.